Now it's my pleasure to bring onto stage Dr. Sarah Foohey from Peterborough, who's going to talk to us about something very Canadian, hypothermia resuscitation. Dr. Foohey.
I'm very excited to be here today in person. I'm more than just a torso, for those of you who know me through Zoom. I'm going to talk to you about one of my favorite topics, the patient who presents hypothermic and cardiac arrest. I love this topic because it's rare, it's complicated, and it's just a little bit controversial. And I've loved it since I had this case. So picture this. I'm 6 months into practice during that new staff, butterflies in the belly before every shift, like pump up music in the car, stage of life. And a few minutes into my shift, we get this patch. It's a 75-year-old woman with no past medical history. She's been found pulseless in her garage. It's December, and her temperature is unreadable. So what I'm going to do today is go over a practical, step-by-step approach to how to manage patients like this, and then talk to you about some of the lessons learned from this case and others I've been involved in since. But first, some basics. We know that hypothermia through a series of cardiac arrhythmias eventually leads to death. And we know that after cardiac arrest, a patient becomes cold or hypothermic. But what's most interesting is that hypothermia also mimics death. So a patient who's profoundly cold will have absent corneal reflexes, non-reactive pupils. You won't be able to feel their pulses. They won't have reflexes, and they'll be stiff. We also know that the cold protects the brain. So at 18 degrees, a patient can survive cardiac arrest for 10 times longer than at normal temperatures, 10 times. And that's because the brain requires less cellular oxygen. And that's how we hear about these absolutely crazy, outrageous cases, with CPR going on for 6.5 hours, leading to a good neurologic outcome, with the lowest recorded temperature ever survived being 13.7 degrees. And from this emerged our mantra, you're not dead until you're warm and dead. Now, when I was standing there in that resus room, this mantra did not help me, because warm is an adjective, and we try not to guide our resusses with adjectives, usually. So I want you to forget it and remember this instead. You're not dead until you're 32 degrees and dead. What this means is, at 32 degrees and below, it is possible that the primary cause of the patient's arrest is the hypothermia. All right, into our approach. I want you to think about this approach in 3 stages. We're going to start with our first 10 minutes, then we're going to call ECMO. If ECMO says no, then we're going to rewarm the patient to resuscitate them. In our first 10 minutes, we're going to start with the basics, our typical ACLS, compressions, early airway management, epi, defib. I'm going to talk about some modifications to ACLS, but when you get started, just do your usual routine. Then you're going to do the easy rewarming strategy. So strip them of their wet clothes, put a blanket on, get the bear hugger on. Because I want you to focus and spend most of your mental energy on this question. Should this code be run, or should you stop? First, of course, if there's a valid, updated DNR. Next, if the patient arrested and then got cold. So obviously, rewarming the patient is only going to help them if the cause of their arrest really is the hypothermia. If something else happened first, there's no purpose to rewarming them. So you're going to do a careful history and physical to look for clues that there was another primary cause of the arrest. So if there was a witnessed arrest, if there's an obvious lethal injury, if there's ice in the airway, or if they're so frozen you can't do compressions, you're going to stop. If the potassium is greater than 12, you can consider that as a reason to stop. Now, no one has ever survived. There's never been a documented case of a person surviving with a potassium greater than 12. But despite that, almost all the resources and guidelines use the language consider, because there's some thought that perhaps lab error or medication problem could falsely elevate the potassium. So you're just going to use it as one of your factors. Next, if you've reached that temperature of 32 degrees and there's still no signs of life, you're going to run this like your typical arrest and go through your termination of resuscitation. Because at 32 degrees and up, you can no longer blame the arrest on the hypothermia. You might consider using a score. So the HOPE score is an online calculator that's used to determine the percentage survival probability for patients with hypothermic cardiac arrest who receive ECLS like ECMO. So you could go online to the website I've listed here and use it to calculate what you think the patient's survival probability is. It might make you sound a little bit more official when you talk to ECMO. And then the last thing you need to do is to get a core temperature. So obviously, since the whole point of this resuscitation is to warm them up, we need to know what temperature we're starting at. Now, in the absolutely unforgettable words of one of my favorite former sim educators, we are not interested in the temperature of the poopsicle. If you put in the rectal probe and you just are getting the temperature of frozen stool, that's not useful for you. So if you are going to use the rectal probe, it has to go in at least 15 centimeters, and even then you have to be mindful that it's going to lag significantly behind the true core temp. So we should use is this, the lower esophageal probe. And when you look at this picture, it's pretty obvious why that is. The lower esophageal probe is directly adjacent to the heart, so it's a much more accurate representation of what the core temp is. However, as most of you probably know, the temperature probes we use are very wiggly and hard to manipulate and hard to move, so it can be a bit difficult to place it here. One of my favorite methods and tips of how to do this is the MCRIT approach, which describes after intubation is complete, using a second ET tube to deliberately intubate the esophagus and use it to thread the probe through that tube, followed by the removal of that ET tube. And there's a great video on MCRIT. You can look for more tips about how to do this. So this is our first 10 minutes. We're doing our basic ACLS, the easy rewarming strategies. We've made sure there's no reason to stop, and we've got our core temp. With that data, we're going to call ECMO. ECMO is the most important thing you can do for your patient. It has a much higher survival rate than anything you can offer in your local emerge. Now, the numbers range from 10 to 60%, depending where you read, and obviously they're hugely influenced by selection bias. One paper showed that ECMO has a 6.6 times higher survival rate than other rewarming approaches. It's incredible. Despite that, ECMO might say no. They often say no. I'm sure at least some of you here have experienced that moment of frustration. And then you're stuck. So if you really think this patient has a hypothermic cardiac arrest, then you know they're not dead until they're 32 degrees and dead, and you're going to transition to phase 3. This is when we're going to rewarm the patient to resuscitate them. The first thing you need to do is call for help. So when I talked to the nurse educators at my former hospital about the one thing they wanted me to share with people, it was this: call for help early. Be very clear. You may need to do CPR for hours. Running and managing these rewarming strategies is very, very labor intensive. So you may need to call in nurses from other parts of the hospital. Rally any students you have around, paramedic students, nursing students, med students. Call in backup. Do what you need to do to run this without leaving the rest of the department completely stranded. Then we're going to transition to our modifications to ACLS for the patient who's hypothermic. The first I've already alluded to. So if this rewarming approach is going to take hours, to do CPR for hours is very labor intensive. So if your department has access to a mechanical compression device, this is a great use case for it. Next, it's very difficult to feel pulses in these patients. So it's an excellent opportunity for us to pull out our bedside ultrasound and use it for our pulse checks. On to the controversial bit. So the bottom line is this: we don't know if epi and defibrillation really works. So therefore, we don't know if we should use it in this context. With respect to defibrillation, the hypothermic heart is very, very prone to VFib. So even if they're shocked after, it's very likely they're going to degrade right back to that VFib rhythm. And we know that people can survive prolonged VFib arrest in this context. So what's the point? Epi is even a little bit more complicated because there's some suggestion from animal studies that epi can build up to toxic metabolites and cause harm to the patient. More practically, if you're going to be doing this code for 2 hours, you just cannot be administering epi every 5 minutes. You're going to drain your hospital dry of epinephrine. So it's not a practical use of resources. So what are we going to do? What I want you to remember is this: you're going to do epi and defib times 3 till 30. 3 doses of epi, 3 attempts of defib, and then wait till you hit 30 degrees. And I didn't just make this up. So this comes from 3 guidelines. These are the 3 main guidelines that I could find that cover the topic of hypothermic cardiac arrest. We have the European guidelines, which are quite conservative. No epi, defib times 3, and then leave it. Then we have the American guidelines that are pretty aggressive. They say, we don't know better anyway, so just do your typical ACLS. The British Columbia guidelines, which are the only Canadian guidelines we have, in a very Canadian way, are kind of middle of the road. So they recommend 3 doses of epi, 3 attempts of defib, and then as guided by clinical response. So this, epi and defib times 3 till 30 degrees. After 30 degrees, you're going to go back to your typical approach to defibrillation, with the thought being that at this point, it's more likely to be effective. You're also going to start giving epi again, but you can give it less often, every 6 to 10 minutes, just because it takes longer to metabolize, so you don't need to give it as often. While we're managing our ACLS, which really, after the first 3 attempts, is just ongoing compressions, then we're going to focus on rewarming the patient until that target of 32 degrees. There's a huge array of options we have, and I'm going to go over them. They correlate with the more complex they are, the faster they work, which makes sense. The gold standard is ECMO, which can warm a patient at 10 degrees an hour or more. It's incredible, but obviously it's extremely resource intensive. On the other end of the spectrum are the easy things, the blankets and the bear huggers, the things we did in the first 2 minutes the patient was in the room. They don't warm the patient, but they do prevent further heat loss in the cold resus bay, so they're still important. Then we have kind of the easier, more common things, the things that you can delegate. So you can use warmed fluids to do continuous bladder irrigation. You can make sure the oxygen you deliver is warmed and humidified using either high flow or the vent. And when you administer IV fluids, they need to be warmed. Now, as you can see by the numbers in brackets here, IV fluids do not actually warm the patient up, but they prevent further heat loss when you do administer crystalloids, which would be what would happen if you don't warm them. Then we have the more complex, fun, procedural options. So we have peritoneal lavage, where you could place a PD catheter and still warm fluids for about 10 to 20 minutes and then drain it out. We could use hemodialysis, where we place a line and then use it to instill warm fluids as well. These options work if you know how to do them, if you have the supplies, or if you have personnel at your hospital available to come help you. Finally, we have thoracic lavage, which is probably the method that encompasses a skill set most of us are more comfortable with, where essentially we use chest tubes to instill warm fluids into the chest cavity and then drain them out. I'll talk more about that in just a minute. But first, I want to delve into some kind of practical lessons learned. So I was lucky enough to do a sim about this in my R3 year, and I studied it for my EM exam. But these are the things that I didn't fully understand until I had a case of my own. The first is the practicalities of how to warm fluids. So we've already gone over it. We're going to need warm fluids for the IV, for the CBI, for chest tubes, potentially on both sides. Where are we going to get these fluids from? So the best methods are the fluid warmer and the level 1 infuser. This is the most accurate, it's the most reliable, and it's what your team is probably more comfortable using. If you work in a small center and you don't store one of these in your emerge, it's worth calling around the hospital. Does the OR have one? The chemo suites, dialysis suites, ICU? Hopefully you can scavenge one from somewhere. For the CBI bags, those big bags of normal saline we use, they can be swaddled up in a blanket and put in the blanket warmer. Leave them in there for 10 minutes or so, and then that's how you can warm the fluids for the CBI part of it. Make sure you have the temperature on the blanket warmer turned to 42 degrees. Sometimes it's actually kept a little bit higher than that, so just to make sure you're not heating it too much. On to the second area of controversy, the microwave. So when I was a med student, I did several rural rotations, and in one of them, I saw one of my preceptors use the microwave during resuscitation for fluids. Seemed reasonable to me at the time. So when it was my turn to lead the code as a staff, I recommended and we did use the microwave. And without meaning to, I caused a little bit of a stir, because as it turns out, most hospital and nursing protocols specifically say you should not microwave fluids. When I tried to delve into why that was, there was some thought that maybe it could cause internal burns. When I tried to research that to see if that was feasible or evidence-based, there's really no case studies or evidence to support this. Practically though, what I can tell you is that the microwave probably just does not work as well. You can tell just by holding the bags that they're not heating evenly, they don't retain their heat as long. So it's definitely not as good an approach. But I want you to include this in your toolbox, because if you're working somewhere that doesn't have those other options, this is all you have. So you can take a liter bag of normal saline, put it in the microwave for 2 minutes, and just be aware of the limitations. On to thoracic lavage. So the concept of this is very easy. You want to put warm fluid in, bathe the heart, and then drain the fluid out. And when you look this up online, on Google, which I did during this resuscitation, this is the picture you see. This is used on every blog. Every foam resource uses this picture, so I know it very well. And it describes using a mid-clavicular approach to a pigtail to instill the fluids, and then an axillary chest tube to drain the fluids out. When I was standing there looking at my patient and my team, I knew there was no way I was going to be able to do a mid-clavicular pigtail. At that time, I didn't feel very comfortable with pigtails, and the mid-clavicular landmarking was so close to where CPR was ongoing, it just didn't seem safe. So I did this, and it worked. So I want to offer it as an alternate. So you can use either a pigtail or a small bore surgical chest tube to instill the fluids in the more superior anterior axillary line, and then use a second chest tube, just making sure it's more inferior and more posterior, so you have gravity on your side. You can do this on the right side or bilateral. Some resources say you should just do it on the right side because the heart is so irritable and it could make the heart more prone to arrhythmia, but in this context, we're in cardiac arrest, I would recommend we do it bilateral. If you do use a surgical chest tube to instill your warmed fluids, this leads to the second dilemma I had anticipated, which is that the end of a surgical chest tube is just that, it's a tube. So to connect that to the fluid tubing we use for the fluid warmer or the level 1 infuser, you need to MacGyver a bit. Probably the best approach is to do this, to use some kind of adapter, like an NG tube adapter that you can put in the end of the chest tube and then connect it directly to the fluid tubing. I didn't know that, so we did this and it worked. We just stuck the fluid tubing in, we taped it up, made sure it was secure, it was effective. The other thing I didn't anticipate was just how wet this would be. So picture this. We've now made 4 cuts in the chest wall and CPR is ongoing, and with each compression, fluid is just like coming out of these cuts. And they're going on the sheet and the bed. There's like a little puddle on the floor. It was a whole situation. So you have to be prepared to be changing the sheets and make sure it's safe for your team. Unfortunately, a few months later at the same site, our team had a different case, and at that time, we just acquired this new fancy mechanical compression device, and we tried it out, and it got wet, and then it stopped working, and we had to send it away. So that was the feeling of the group. So kind of anecdotally based off this, the last hospital I worked at had decided that maybe thoracic lavage wasn't for us because it wasn't that tidy, and dialysis was preferred. You might not work somewhere where you have dialysis as an option, or a nephrologist or an ICU doctor or yourself who's capable of putting in the line. So it's still a feasible option, but just be prepared for this. Some general reflections. So you need to establish a shared mental model with your team. I can guarantee you there's going to be at least one person in your room who thinks this is an outrageous thing to do. What's the point of doing CPR for 2 hours? This person's never going to have a good outcome anyway. So it's very important that you let everyone on the team know that in the context of a hypothermic arrest, this patient actually could have a good neurologic outcome, even after hours of CPR. And that's why you're doing this effort. That's why you're putting in the heroics. Next, we've already gone over this, ask for help. You can leave the room. So this was hard to do as a new staff. I felt like I did not want to leave the room till we hit 32 together. But you have to. So you can't let your department grind to a halt. So once you're established in that rewarm to resuscitate phase and things are ongoing, you have to leave, see other patients, and then come back. You have to choose rewarming techniques that work for you and work for your setting. So I've run this sim case many times now, and I've talked to lots of people about it, and I find this topic brings out a lot of very strong, kind of emphatic opinions, and most of it's because people have seen a case that worked well or didn't work well. So people are going to have thoughts about what you should or shouldn't do. At the end of the day, you're going to choose the rewarming technique that you have supplies for, that you know how to do, and just commit to it. On that note, it's not a bad idea to consider some kind of department policy, either a formal policy or more of just like an informal consensus, so that way at least you know that everyone on your team is on the same page. I've made this one-slide summary, which is not intended for right now, but that you guys can reference later, that we have posted with the resources, and this has everything you need to run these codes. I can guarantee you will have plenty of time to look things up on your phone while you're running these resuscitations. So it's a good idea to have this or whatever resource you like just available, saved in a folder, just in case you need it one day. But what I want you to remember is this. When you receive that patch, when you walk into the room, I want you to know 3 things by heart. The first, you're not dead until you're 32 degrees and dead. The second, you're going to call ECMO early. And finally, you're going to do epi and defib times 3 till 30 degrees. Thank you.
Oh, wait, Sarah, hang on for a sec. We may have a question or two. We're going to, no, not quite out yet. I'm someone you could call for help with the temperature probe because I am amazing at intubating the esophagus.
Okay, great. We've got the man for it.
Any questions popping up from the schedule here?
Yeah, there were a few. Yes. Hello, check. There were a few questions from the virtual feed. One being that the transfer to ECMO and or an ECMO team coming to your center, I'm sure is filled with practicalities and prepping the patient for ECMO. Do you have any suggestions of how any of that works or any practical tips?
Yeah, that's a great question. There's some really good resources out there that are meant more for EMS providers, but the takeaway point is if you're transferring to ECMO, you're not going to be doing a lot of these really invasive procedures like thoracic lavage. So really, you're going to have an intubated patient with the lower esophageal probe temperature in place with 2 large bore IVs. And then the EMS can do this like burrito technique. If the EMS has it locally, you can ask them where they use insulated blankets and kind of swaddle them up. If you work somewhere like BC, most of the land crew should have them. If you don't, you might just have to do your best with what you have locally. But I would say that's a great question to ask ECMO. Before transfer, what do you need? How can we warm them? And it may kind of have some variability.
Excellent. The other question that I had was with regards to epinephrine and cardiac arrest. We know that for outpatient cardiac, for out of hospital, cardiac arrest, that there's really no good evidence that epi improves neurologic outcomes at discharge from hospital. In terms of the 3 doses sounds perfectly reasonable. What about the idea of using an art line and the diastolic blood pressure in particular to help guide how much epinephrine you're giving? That seems to be something that's sort of a trend now, rather than just guessing and giving 3, because we know that there are harms from giving too much epinephrine. Any thoughts on that?
I think that's a great idea. Whether we'll ever have evidence to support in this patient population is so difficult to know because they're so few and far between. The only challenge I can foresee is that doing an art line is quite tricky the best of time for most of us, and with these patients where it's going to be really difficult to feel pulses and even with the Doppler see it, may be a bit logistically challenging, but I think if you have the skills, the resource, and the time, that's probably a good idea to help with your epi.
Great. Thank you. Thank you very much, Sarah. So we're going to